All right, it's my delight to introduce you to a powerhouse attorney. She has made a huge difference across our state. She works with hospitals and healthcare systems and healthcare people and telemedicine. She works with me, and I've known Michele Madison for many years. And honestly, when I emailed her to see, could you speak, I was shocked when she said yes. And because she's so busy, I didn't know that I could get her. But she's a partner with Morris, Manning, and Martin in Atlanta, and you can look at her biography that we've got on there. But she's a great speaker, speaks around the state, and we are privileged and delighted to have Michele Madison. Thank you.
I'm going to need Lloyd. Rena, you have any idea how to bring up slides?
Oh.
There's Lloyd. We need you.
Chris got it.
Okay. While you're doing that, I'll just say, Dr. Sumner, total powerhouse, but I was in the Georgia legislative delegation giving a talk on digital health, and I was coming after her, and I had to give this talk, and of course she didn't give the talk. She was like on an ambulance with that thing that you look into the ear, and she's like doing a live visit in the legislative, and I'm like, really? I gotta follow this? So she's amazing, and I love working with her. So today I'm going to talk about the legal landscape. So we're going to talk about the licensing and the changes that have happened as a result of COVID. And as Rena said, I work with a lot of different areas. So with digital health, during COVID, we had a bunch of digital health clients, and some of which did telemedicine, and you just watch the numbers just increase during the pandemic. And that is going to continue, and especially in behavioral health. So I'm going to touch on that today because that is a massive focus in the Southeast and especially in Georgia. I'm going to talk about reimbursement. There is a Excel spreadsheet that Medicare put out in November of this year, so now, that talks about the reimbursement for next year, and I will send you guys that spreadsheet. It's easy to get to, but I'm going to talk about the different areas where they're continuing to provide Medicare reimbursement in a way that we hadn't received it before. And then I'm going to talk about some new Georgia laws, of course, my favorite topic, which is HIPAA and privacy and security. And then fraud and abuse. I want to talk about some of the things that people have done related to telemedicine that I am positive none of us in this room have ever done and won't do in the future, but I want to tell you about them because it is billions of dollars of fraud and abuse that the government is focused on. And there are a lot of people who have just kind of taken advantage of a industry and a tool that can help patients, but they've taken advantage of it in a bad way. And so I want to give some examples of what's happening. But first and foremost, licensure. So with telemedicine in the state of Georgia, we have the ability to have compacts with other states where if you are licensed in another state, you can come into the state of Georgia, but you still have to go through the state licensing board. So if I'm licensed in South Carolina and I want to practice in Georgia, I still have to be licensed in Georgia. There is a compact that they will use to speed that up. For any of you that have hired doctors lately, you'll know it takes a while to get a license. But during the COVID pandemic, and now it's permanent, you can get what's called a telemedicine license in the state of Georgia. And what that means is you are licensed in another state, you're in good standing, so you can't have any infractions in that other state, and you meet all the requirements that we have from a licensure perspective. So you have medical school, you've got residency, you've had your training done, and here's the biggest kicker, is you cannot have an office in our state. So a lot of docs say, well, that makes no sense. Why would I have a telemedicine license and not have a license in your state? And some of that is protective. So we have a lot of physicians in our state who say, well, if someone can come in and do telemedicine here and develop a patient relationship and then open their own office here because they got in faster with a telemedicine license, then I'm in jeopardy of losing my patients to a doc who got in a lot faster than I did. So we protect our physicians by saying, hey, it's totally fine if you're licensed outside the state and you want to provide telemedicine services to patients in our state, that's fine, but you can't have a physical presence in our state. We would like for you to visit our state, and if you're on vacation here, you still can't give telemedicine when you're on vacation unless it's an emergency. So Florida has the same rule. So they just recently passed a rule where, and I've got a lot of docs who are in the Northeast, but their patients go to Florida in the winter. And so they're like, well, am I giving up my patient? I can't order scripts for them. I can't treat them when they're on vacation in Florida from, Thanksgiving until Easter. I lose my patient. So Florida has a similar rule as Georgia. You can get a telemedicine license, but you can't open a physical practice in the state. You do have to have a registered agent in Florida. So for the companies that provide remote registered agency, it's a fascinating business opportunity in Florida. In Georgia, we don't have quite that same rule, but we do have the rule that as long as you meet all the requirements, you can have a telemedicine license, you can provide telemedicine consultation to your patients, but you can't physically be here. And then you also have to maintain medical records under Georgia law. So if I'm in South Carolina, and I'm going to make this up, let's say South Carolina says for adults you only have to keep records for 7 years. Well, in Georgia, you have to keep them for 10 if you're a physician practice. If I'm in South Carolina, I have to keep those records for 10 years. So you have to follow the Georgia rules, and you have to document your visits. So for a long time, we used to do these telemedicine visits where it didn't necessarily document everything that was happening during the telemedicine visit, but we were billing for it. Now that's a big audit area for the payers. They'll come in and say, produce your medical record to me so I can see what you did to back up that reimbursement that we gave you. So same thing with a telemedicine license, you have to keep all that documentation in place. All right, so from a telemedicine perspective, I want to mention one other thing. During COVID, there were some states who said, hey, if you are adjacent to another state, you can cross state lines and provide those services. Georgia requires that telemedicine license. It is a very big deal to come into our state and practice without a license. That will get you reprimanded and potentially mean that you'll never have a license if you ever applied in the future. So you absolutely have to have a telemedicine license if you're going to do telemedicine services from out of the state. If you're already licensed in the state of Georgia and you have a practice, you don't have to get a telemedicine license. You are a licensed provider and you're authorized to do telemedicine services. All right, so what makes telemedicine stay? Lots of things. One is the remote areas that we're dealing with. When I go from region to region in our state, if you look at the community needs assessments, one of the number one needs assessments in most of our counties, at least in South Georgia, is transportation. We have a massive transportation problem. So telemedicine helps us solve that problem. So one thing that keeps telemedicine at play is our ability to provide services to individuals who can't get to an appointment. One of the crisis areas that we had during COVID, the beginning of COVID, was that people weren't coming to the hospital and they were staying home, and so their preventative care went to the wayside. And then when they did come back to the hospital, it was almost like that crisis emergency because everything that had happened over the last 9 months hadn't been treated or they hadn't detected things. And so from an oncology perspective to congestive heart failure patients, we had real issues where we needed to have intervention in that meantime with those patients at home. And so telemedicine is our answer to that. Historically, we could do telemedicine on a Medicare perspective in rural areas. And when this unfortunate pandemic broke out, we were allowed to do telemedicine anywhere. So I will share with y'all, and I've shared this at other talks, I did my first telemedicine visit during COVID. I was at the beach, so I was in a good place, great originating site at the beach. And it was when they said you don't have to worry about HIPAA compliant things. So the dermatologist said, just let's do FaceTime. So I'm not a FaceTime girl. FaceTime makes my face look fat. I don't like FaceTime. So I was like, all right, we'll do this. So it was about a 3-minute consultation. And the whole reason that I had even scheduled a visit, because as an attorney, I never go to the doctor. I just represent them. And so she looked at my face and she's like, oh, it looks fine. And I was like, can you see my face? I didn't know what she was looking at. And the only reason I even made the visit is my husband was like, you have this spot. And he had a spot and it wound up being melanoma, so he gets very paranoid. He's totally fine now. He's just paranoid. And so it literally lasted 3 minutes. Well, 6 months later, I got the bill and it was, we pay as if it's an in-person visit during COVID. All the insurance companies did, and we will going forward in the future. And I had a 99215 visit for a 3-minute telemedicine visit. So she clearly didn't know I was a healthcare attorney. But I didn't raise any issues. It's all good. But that was my first experience with a telemedicine visit via FaceTime. So now when I go to my practices, a lot of the practices have actually set up telemedicine as a daily routine because during COVID, we got used to seeing our patients via telemedicine. So we have nurse practitioners or physicians, and we schedule time in a lot of the practices, like every Tuesday from 8 to 12, we're going to do telemedicine visits. And now I'm much more comfortable and I don't do it via FaceTime, and it's all via normal stuff. Not that FaceTime's not normal, just makes me look fat. But we're going to continue to see telehealth offered in lots of different originating sites. Today, because we're still under the public health emergency, which by the way continues until January, and then we do believe it's going to get renewed again for probably until April, around tax time, April 15th. And the reason we think it's going to get renewed again is, number one, on my way down here today, they were talking about an uptick in COVID cases, but not in Georgia. But then number two, the government told us, so just hear me out, the government told us that if they are going to end the public health emergency, they will give us 60 days advance notice. Well, we're in December, it's supposed to end in January, we haven't heard anything. So we think it's going to go until April. So we'll be able to provide under Medicare telemedicine services at least through April in any originating site. It will be determined later as to whether or not those telehealth visits will have originating sites that are not in rural areas. And right now, I think it's going to go back to originating sites in rural areas, but we will have some expansion of services. We expanded a lot of services during the pandemic to include physical therapy, speech therapy, hearing aids, eye exams. All of that was covered via telemedicine visits. Medicare also put out a guide where they could do phone visits, so you don't have audio and visual, you just have audio. And there are some visits that at the end of next year will no longer be allowed to have audio. And there are some visits that will remain audio forever. So what we call virtual visits that are audio only, those will continue under the Medicare telehealth benefits. We are going to see a couple of different buckets. So what you're going to see are telehealth visits that became reimbursable under Medicare during COVID continue indefinitely. Because during the telehealth time, we realized that those visits were effective for patients. Then we're going to have some types of services that are going to end on December 31st, 2023 as being Medicare covered, and I'm going to talk about that in a second. And then you're going to have visits that are going to be covered by Medicare through the public health emergency, so we're talking April of next year, and then 151 days afterwards. I don't know why 151 days, but 151 days after the expiration of the public health emergency, there are some services that will continue to be covered by Medicare to allow us to gradually move back into a different way. So these are the types of services, and there are CPT codes associated with each one of these, but if I listed every CPT code, it'd be 236 of them, so I figured y'all didn't really want that, but I'll give you the spreadsheet and you can send it out. But so hearing and auditory testing, that's going to continue via telehealth through December 31st, 2023 for Medicare coverage. So when you look at the next couple of slides, these are Medicare coverage only issues. Speech therapy, ESRD for patients that have had dialysis services for less than 2 months, that's all going to end at the end of next year for reimbursement. Orthotic and prosthetic training, self-management education for patients, and then hospitals and nursing homes. So this was a big service during the public health emergency, is being able to give a telehealth visit to a nursing home patient or a hospital patient. Massively needed. And so that will go away at the end of next year because we're kind of back into seeing patients inside the patient care setting in those two facilities. And then emergency departments. So this pandemic kind of knocked us all in our ear. It was the most interesting way to deliver care and the most interesting phone calls I've ever had in my life as a healthcare attorney. There were nights that, and I moved my office to my basement on March 18th when we all went home, and I thought I was going back in 2 weeks, but that didn't happen. But as I'm sitting in the basement, work became 24/7 because supplies became so obsolete that all of a sudden we were on the phone at 2 and 3 in the morning figuring out when masks were coming into an airplane in Hartsfield at 2 in the morning to then arrange it the next day to get out to the hospitals. It was a bizarre life, bizarre. One that we learned a lot from. But one of the areas that I think we learned the most from in the emergency departments were the influx of the patients that were coming in so sick and our desire in the emergency department to not have them come inside the physical building. Like, how do we screen them outside so that we can get the patients that need to be in the ICU into the ICU? And telemedicine was our answer. So we would set up the tents and we would have the physicians inside looking at the iPads, doing a telemedicine visit with the nurse who was in a hazmat suit, for lack of a better term, outside, and then we would have the patients lined up based upon where they fell in our screening. Telemedicine was our answer for that. And if we didn't have telemedicine, we would have had an influx of people inside the facility. And remember, this is back when we didn't know how to control the spread. We would have had a spread inside of an entire facility. So the emergency department will continue, and that'll continue through the end of next year. And I'm interested to see what CMS does after that, because we will have other issues that will come up where we'll have to revert back to this delivery of care. So that'll be there. And then cardiac rehab and pediatric critical care. So there are two things that I think are essential in our state that we need additional services on. One is pediatric care. Every place I go, we have a lack of pediatricians. We have primary care doctors that are providing care for critical care patients in pediatric units. And then we have behavioral health needs, like there's no tomorrow. We have patients that present in all of our facilities, and we have nowhere to send them, and they have no psychologist, psychiatrist, or behavioral health staff on the medical staff. So those two areas are areas that I'm very passionate about because we have to solve that problem for Georgia, and maybe we can be an example for others. But for pediatric critical care, we're still using telemedicine because of that lack of providers in our state. We just have a complete absence of providers. And so in this instance, this is supposed to go away at the end of next year. Obviously, Medicare is not a pediatric reimbursement. It'll dovetail over to Medicaid. And then cardiac rehab with and without exercise will go away at the end of next year for telemedicine. Now, these are the types of services that are going to continue until, I'm saying, April. It could get extended past April, and then another 151 days. So geri psych, acute care, nursing care. We still have the pediatric critical care codes. Hospital observation. So Medicare has made a change on what they pay for in hospital settings, and you've seen a big shift that patients are becoming more observation-based. So we use a lot of telemedicine on observation-based patients, especially in our rural hospitals. So that will continue through the public health emergency and 151 days later. So what does that 151 days do? It gives us more time to assess it, to figure out, is this something that we should be using telemedicine for forever? And let us make the right policy decisions going forward. And their nursing care inside the nursing home facilities, and then physician home visits. So these codes, so remember earlier I said Medicare lets the docs do audio only for some virtual visits. These codes are the ones that the docs are documenting under, and those are going to go away 151 days after the public health emergency. So what I think will impact those codes and whether or not they stay Medicare reimbursed is whether or not broadband reaches all the areas, or if we still have pockets of areas where people can only communicate by phone. And I think that will drive that policy decision. And you will be stunned when you look at the map of where we don't have enough broadband in our state. It always makes me crazy. All right, you're going to hear me talk about mental health all morning. It's not because I need mental health services, it's because it's a massive critical area in our state. It's amazing to watch the impact of COVID on the healthcare industry, but the impact of a pandemic emotionally, physically, and mentally, just on the person walking down the street, has been dramatic. And watching people try to reacclimate back out of a pandemic and into normal socialization has been hard for a lot of people. Younger kids, remember, a lot of them went home from school and then went back into the school setting. And then we had a lot of lack of social interaction. So I can completely tell the difference in my kids when they've been with their friends, some good, some bad, versus when they've been at home doing whatever it is they're at home. There are very different ways that they behave. And so that lack of social interaction, we've seen that really impact pediatric patients. So with telehealth and mental health, so we have TeleMental Health, this is going to be an area of expansion that we're going to see not only in the state of Georgia, but across the board. So for Medicare, for TeleMental Health, they're going to get rid of that originating site requirement that you have to be in a rural area, because it's not only people in rural areas that need mental health services, it is people in urban areas. If anyone drives in Atlanta, you know what I'm talking about. So Telemental health in urban areas is needed as well, but what they're going to do is they're going to say if you're not in a rural area or you're not at an originating site that was originally approved for telemental health, then you have to have a visit 6 months in person. So in other words, once the public health emergency ends, if I'm a psychologist or psychiatrist treating my patient, I have to have a telemental visit in person with that patient, and then I can do telehealth visits for 6 months, and then I have to see the patient once a year, every 12 months in person. Now, if I'm in a rural area and it's unable, we don't have the ability due to transportation or whatever other reason, I can document patient in rural area, originating site rural area, inability to see them in person, and that'll be waived for purposes of the Medicare reimbursement. So they're trying to make telemental health services more available regardless of where you are sitting, whether you are in your car on 285 and you need a visit, or if you are in Waycross and you're at home. So just making sure that everybody has access via telemental health. My concern about the access is that you've got to have a provider on the other end. So getting the providers has been one of the most difficult parts. And just before I go to reimbursement in Georgia and other states, when we look at coming out of the pandemic, and Georgia was one of the first ones to remove its public health emergency, and we saw the influx of patients who came into our emergency departments. If you go into most of the emergency departments in our state that are in rural or medically underserved areas, we have, let's say we have anywhere between 8 to 12 emergency treatment areas, okay? They're not necessarily rooms, they're treatment areas. And we have typically dedicated 2 of those rooms for patients who either have said, I want to hurt myself or others, or I'm having an anxiety attack, I'm having a mental health stressor. And in those 2 rooms, it's not that we have psychologists or psychiatrists that we call down and say, please come down and see the patient. They don't exist anywhere. We literally do telehealth with physicians and psychiatrists who are in South Georgia. A lot of these psychiatrists are in North Florida on the Panhandle because there are 2 or 3 there that are licensed in Georgia that will contract with us. That's how sparse the physicians are. We can't even get them other places. So that's an area that's a huge issue. But the other part that's really a crisis for our hospitals is even when that assessment happens and they say, yes, we need to 1013 that patient, I'm in a little emergency department that has a nurse practitioner. I have a nurse that's there. I have a psychologist or psychiatrist from Florida who says the patient needs to be 1013, and I have nowhere to send them because we have a lack of psychiatric beds in our state. And so that is the crisis that we'll have to deal with from a treatment perspective, I think partially using telehealth, partially making the state aware of that crisis need. Now this map I did not create because I cannot do graphics, but Manat created it, and I love this because it shows the 21 states that have said if you pay for an in-person visit, you're going to pay for a telehealth visit in the same manner, in the same amount that you would pay for an in-person visit. So Georgia, as you can see, is one of the leaders in the Southeast. These other states, some of them pay for just mental health, telemental health services. And then in New Jersey, they'll do it through the end of the year. I don't know what happens in New Jersey in 2024. I don't know. But they may have to change the rules. And then Vermont will do it through 2026. So I think they're testing the waters to see how much of an impact is that from a cost perspective, especially on their Medicare and Medicaid payers. So from a Georgia perspective, I have always found that Georgia is one of the states, and I think it has a lot to do with the Rural Innovation Center and the Georgia Partnership for Telehealth and Dr. Sumner's leadership and Rena and all the people that have been involved in our state really taking telehealth and showing the world that we lead in telehealth. And so when we have done policies in the state of Georgia, we are typically ahead of the game. So when you look at that map and the fact that we're the one in the Southeast that passed that law, I think it says volumes about our state. But basically what the law says is that insurance companies have to provide for benefits and coverage through telehealth. Now, I have an app from my insurance company, and they ping me all the time about who the providers are that they have on panel to do telehealth visits, because they know that if I do a telehealth visit and I get preventative care, that's going to prevent me from probably being a crisis admission in an emergency department, costing them a lot more money. So insurance companies are required to include it in their benefit services, and I bolded this language, that they have to provide the same amount for the in-person visit that they do as for a telemedicine visit that they do for an in-person visit, which I think is really important because I gave you the example of some of the practices that I work with, and they set up those days or half days where they have a provider that just does telemedicine visits. One of the issues we had with that is not all patients like telehealth right away. Like, they have to get used to it. And so one of my docs said, well, if I'm not going to get paid for the visit, why would I dedicate my time to that? I should just be calling the patients and having them come in. And it took him realizing that not all of his patients can reach them. Some of them live in rural areas. They have no way to get there. So in order for him to see the patient, he has to see them remotely, and the fact that he's going to get an in-person reimbursement motivated that to make that whole service line available in the physician practice. And it wasn't just one doctor that was worried about the payment. It was a bunch of doctors. The other part is you can't have lifetime limits. So remember, with healthcare reform, we changed how insurance has essential health benefits and no maximums on the dollar amounts. We also in Georgia have a parity law related to behavioral health. So if you're offering a in-person visit or a physical exam service, you also have to offer it from behavioral health. That just passed last year, which I think is a big deal for our state. And I think it's recognition of the fact that we need to make sure behavioral health services are available. But these are a couple of laws that were passed and went into effect in July of this year that all focus in some form or fashion on the use of telehealth services. So behavioral health, they want to make sure that they have a list of all the behavioral health providers in the state. And when they do that, they're going to identify which ones do telehealth services, so that we will have a website that says, here's all the licensed behavioral health providers in our state. Here are the ones that offer telemedicine. And then for the Rare Disease Advisory Council, which focuses on patients that suffer from rare diseases, they're going to be looking at how do they expand telehealth services and what kind of peripherals do they use to help diagnose those patients and treat those patients. So both laws include a concept of telehealth, and I think that just goes to show how important telehealth is in our state. And then this one I think is critical. Does anybody here work with a community service board or know of one in their region? Yes, so of course you guys do. So community service boards are located in different regions in our state, and they provide a real essential service for our patients and our beneficiaries in our state. This is a mechanism where the law enforcement can partner with the community service board, and a community service board can get on that ambulance or that law enforcement's vehicle, and they can go out to see a patient who's having a behavioral health crisis, and they can use either in-person visits with a counselor, or they can do telemedicine. So like I said earlier, we don't have a lot of providers, so if the community service board has a provider who's in a clinic offering services to behavioral health patients, and law enforcement says, I've got to go out, we've got somebody in crisis and we're on our way, they can bring the machine with them or the iPad or whatever they're using, and they can then visit back to the community service board through that arrangement to give that behavioral health assessment. So I think that's a critical part of expanding services, and it reminds me when Dr. Sumner was on the ambulance in Hancock County doing ear visits. But it's a way of getting out to patients. So we also have a Telemental Health Act in the state of Georgia, and it actually focuses on the ability to do telemental health services. So it's using smart phones, tablets, PCs, and basically being able to support the ability to consult with a behavioral health specialist because we don't have enough providers. So the licensed professional counsel or social worker, so my mother-in-law went back to school for a lot of different degrees, but this is where she landed. And when we go to visit her at home, her entire practice is telemental health. So she never sees someone in person. It's all telemental health. And then there are the marriage and family therapists who can also do telehealth visits. So here, and this is not necessarily covered by Medicaid because Medicaid requires a back and forth audio-visual seeing one another. Unless it's dentistry, they'll let you do store and forward on dentistry for teledentistry. But here, you can do a store and forward. So if I'm having a mental health issue, I could take a picture of whatever it is that's making me anxious, and I could send it to the counselor, and that's still ability to provide telemental health. That's considered telemental health services. Or I could do a live video, Zoom call, or whatever it is with my counselor, and that's another way of delivery. You do have to be trained. So telemental health, you have to have a minimum of 6 continuing education hours related to telemedicine and telehealth. So I can't just go and get 6 continuing ed hours on cardiac rehab. That does me no good. It's got to be telehealth. How do I assess the patient? We also need to make sure we're assessing patients that can benefit from this service. We have some patients that are in such crisis that they physically need to be served. They might need medication right away. They might need some physical intervention. And so we have to make sure we're assessing the right patients. And some of this training is on, is it the right patient? Is this the right patient to have a telemental visit with? You also have to get an informed consent, and this is the kicker, verbal and in writing. So that whole digital sign with your finger, which I did all day on Black Friday, sign with your finger. So we have to be able to have that capacity. And then making sure that we're being ethical in what we're doing with our delivery of care, and I'll talk about the ethics of that in a moment. Telepsychology is also authorized under our rules and regs, so you have to be licensed, you've got to be competent. Standards of care are the same as if you're an in-person visit versus a telemedicine visit. But the confidentiality of this information is critical because remember, psychotherapy notes are super protected. So like HIPAA protects medical records, and you could get a request for medical records, but if you've got psychotherapy notes in your file, you've got to pull them out before you send off the medical records because those are what we call, in an unofficial way, super confidential records. And so you have to have encrypted forms of communication for the record. Medicaid requires encrypted forms of communication. And then you have to secure the data. So when I think about my mother-in-law, she has a secure backup in the cloud that's encrypted to make sure that the data is secure, and then after so many years, it gets disposed of. And so all of those processes and procedures have to be followed. And then testing and assessment. When you are a psychologist, you do certain tests with the patient, and I've seen some telemental health programs where there's an assessment that the patient fills out and then they look at it. But sometimes there's a physical testing or there might be a lab testing. Those are more appropriate for in-person visits. Okay, now my favorite part. Privacy and security. Okay, so as you all know, during the pandemic and the public health emergency, the government said we're going to have to use telehealth. And we realized that there are people coming out of the woodwork and not all of them are HIPAA compliant. And when we say HIPAA compliant, it's not like there's a HIPAA rule that says you do X, Y, Z. There are administrative, physical, and technical safeguards that have to be complied with. And you have to assess based on your program what's the best way of providing care. And the government has what's called addressable safeguards, one of which is encryption. And so you say, oh, well, I can address it, I don't have to use it. Well, they then went and fined a healthcare system $3.25 million because they didn't encrypt their laptops. And so they came back and said, while it doesn't say it's required because you have to do the risk versus the benefit assessment of how expensive is encryption. It's not very expensive anymore. And did you use it? Were you exchanging securely information with a patient? So what they said when all of this started was, we know you need care, use FaceTime, use whatever you got to do, and just don't make it public facing out on the internet, and we will use our discretion not to enforce fines and penalties. However, now they've come out and said, by the way, we're probably going to see this public health emergency end. Now it's probably going to end in 2023. And we want you to start getting ready for what we're going to expect for you to do as healthcare providers. And that is, they want you to protect the privacy and security of the information. So they want you to look at that encryption and how you're using the data. If you're in a setting where you're providing services, be in a setting where you try to seclude yourself into an office, because remember, your patient is 300 miles away and you're talking to them. And if you have other people around, you shouldn't be on a speakerphone. You should have your earbuds in. It should be a secure communication. And then you need to verify who that patient is on the other end. Either have them show the physical ID, have them verify 5 different forms: what's your zip code, what's your date of birth, what's your address, what's your name, those different things to verify who the person is. They want us to know who the person is that we're treating, and then also make sure that we verified it. If it is a phone-only visit, it doesn't require compliance with the security rule, that encryption part. But if it's a voice-over internet protocol, which most of us have in our offices, that is governed by the HIPAA security rule. So you need to look at your risk assessments on your security of your system. It is required to do a risk assessment to look at all the vulnerabilities and risks of your IT system and then address any safeguards to stop any potential violations. When you see the HIPAA fines and penalties, most of the high dollar ones are because someone did an insufficient risk assessment. They failed to notice that they did not have an encrypted database, or they left a portal open, a Wi-Fi portal open that was unencrypted. So looking at, the government says they want you to look at transmissions. How do you transmit? Can it be intercepted by a 12-year-old? Are you using encryption? Where do you store it? Is it in a secure cloud? And then how do you authenticate your users? And then log off. So if I walk away from the computer, does it automatically log off? That's one of the ones that drives my doctors nuts, because I'm always like, don't let it go more than 3 minutes. And they're like, I want it to go for an hour. No. Log off has to be a short period of time. So Medicaid, I mentioned, it does require for the services to be under encrypted transmission. So making sure that we are using encryption is important. And most of us do that today, but the phone can be an issue. The other thing I will tell you, if you are a healthcare provider or you provide any kind of delivery of services being telemedicine, go ahead and look at these forms. Your notice of privacy practices, you need to tell your patients exactly what you're capturing in that telemedicine visit and how you're going to store that data. Make sure you get an informed consent to treat. So Medicaid has a form template that they like. It's very good. So you could literally take the Medicaid form and use it in any other form or fashion. And then make sure you're storing things securely and you've done your security plan. If you have not done your security plan, the government will focus on fines and penalties on your risk assessment. Okay, so the Office of Inspector General did a study, and this is March of 2020 to February of 21, so this isn't even the whole period of time. And remember, they're focused on, in this study, Medicare beneficiaries. 28 million Medicare beneficiaries use telehealth during that 1 year. 13% of them were for E&M visits, evaluation and management visits. 43% were for behavioral health. That's pretty dramatic. So making sure that they have access to behavioral health, this is what's going to drive the policy decisions about what Medicare pays for. And then they saw a whole bunch of stuff that was not great. So how many of you have ever been on the internet and all of a sudden these little ads are popping up for stores that you may have Googled or looked at in the last 6 months? So mine pop up on everything my kids have been shopping for. So then I know what they want for Christmas. There are telemarketers out there who will target Medicare beneficiaries. And so they will put out ads, and they call it clickbait, where the Medicare beneficiary clicks on it and then it goes straight to their computer and it kind of goes into their cookies. And they know who those people are. Excuse me. And so from that standpoint, the telemarketers are gathering information about Medicare beneficiaries, and then they're calling them and saying, hey, by the way, did you know that Medicare offers this for free for Medicare beneficiaries? And I can set up an appointment with a doctor to verify that you can get the order, and then we'll order it and we'll have it delivered to your home. So that's a problem because there's no relationship with that provider. Then there's a second mechanism where the telemedicine company goes to the healthcare provider and says, I've got this whole list of Medicare patients that have clicked on my advertising, and I am willing to sell to you their information so you can then do an online visit or a telemedicine visit with them, and then you can order these durable medical equipment supplies or prescriptions, usually compounding creams, and we'll bill Medicare for you. And the Medicare provider actually never interacts with the patient. They just get the information off the advertisement or the screening, and then they wind up billing Medicare for these patients that never had an actual telemedicine visit. But the provider gets paid, and I'll talk about that in a second. The other one is the durable medical equipment company, laboratory or pharmacy. They actually get the beneficiary to answer a call from a telemarketer. They get their information. They then write up the order for the script, and then they sell it to a provider to then take that order, maybe or maybe not send out the information and bill Medicare for the service. So this was very prevalent in Georgia, incredibly prevalent. So both of my parents are Medicare age eligible. I won't tell you how old they are because my mom would not forgive me, but she would get these calls on her cell phone all the time. This is before Verizon put potential spam on these numbers. And so she'd get these calls about, you are eligible for a back brace as a Medicare recipient, and we can order it for you and have it delivered to your home for free. And she was getting it all the time, and she, of course, knew that this was not how the world works. And so after the fifth or sixth one, she's like, well, that's great. My daughter's a healthcare attorney and talks to the DOJ all the time, and that was the last call she ever got. So that one ended for her, which I was glad. But some of the suspect characteristics are those types of behaviors where the individual telemarketer is reaching out to the patient, and then the doctor will get a list from the telemarketing company, and they will go ahead and order a service, or sometimes they will call the patient or do a telemedicine visit even though they had no prior relationship with the patient, and they'll order the DME or the script just based on that one telephone call or that one visit. And then the companies that are doing this are then paying the providers for those services. In Georgia, there are a number of providers, nurse practitioners and physicians, who these companies came out of the woodwork and said to them, we have a list of patients that we want you to see. Will you do the telemedicine visits, and we will pay you for the telemedicine visit? And so the doctors and the nurse practitioners literally were like, yeah, I mean, I'm an independent contractor, pay me an hourly rate to do this visit, fine. What they didn't do is raise the red flag of, well, where did these patients come from, and did they have another provider that should have been referring them to me in the first place? And then they got to be so voluminous that some of the providers never did the visit. They just rubber stamped the order, and it got billed to Medicare. And those individuals have had their Medicare participation revoked. So the government put out a special fraud alert about this, and they said, look, there are companies like compounding companies or genetic companies or durable medical equipment companies, the back brace companies, and that's the only service they're offering. So if they're coming and saying this is the service that you can get, that's a problem, because you should be caring for the whole patient, not just on this one delivery of service. And if you really only have interaction with that patient one time, that's a big red flag. You should be following up with that patient about their care. So if someone comes to you and says, will you see our patients? I'll pay you an hourly rate, and you only see that patient for 5 minutes, if ever, and you never see them again, that's a red flag. So the government has put together this guidance for providers, and this is very small type, but it's a very long document. I can send it to you. But basically, that providers need to talk to their Medicare beneficiaries. So my mom knew enough to say what she said, because I talk about this stuff all the time. But a lot of Medicare beneficiaries, they don't know. They're getting Medicare Advantage ads at them every 5 seconds. Now that part I did have to walk through my parents with. So they're getting all this advertising. They don't really know. They don't know if they are eligible for these Medicare benefits, especially during the public health emergency. Things were greatly waived and expanded. So talk to your patients about, if you need something, I'm going to assess it. And if we're going to have a telemedicine visit, we're going to have a follow-up visit. And it's not going to be just for your back brace. It's going to be for your whole self. And make sure that the patient understands the type of communications that you as a provider are going to have for them. And tell your patients that if anyone says Medicare is giving something for free to you, that is a red flag. If anyone is saying you're getting something for free, that is a red flag. And if someone comes to you as a provider and says, I can guarantee you $10,000 a month if you will see my patients, that's a red flag. Guaranteeing a certain amount of money to see someone else's patients is a red flag. So all of these things people have to be aware of. There were a couple of enforcement activities in Georgia alone. So this is just one case. This is a nurse practitioner. In this case, just so you know, the Southern District of Savannah worked in collaboration with the South Carolina Assistant U.S. Attorneys, and the two of them kind of went after this. And that's why you see so many cases in Georgia. But this was a nurse practitioner. She ordered more than 3,000 orthotic braces, $3 million in fraudulent and excessive charges to Medicare. And she basically just signed her name to these orders that the company sent over. Sometimes she spoke to a patient, sometimes she did not speak to a patient, but she would just sign the orders for the back braces. But she thought, well, I'm just getting paid for following up on this order for a patient that needs this back brace. She'll go to jail for 87 months. She has to pay $1.6 million in restitution. She is one of numerous providers who got mixed up in that mess. Then we have a telemedicine billing issue. And so earlier when I said, remember when you're doing telehealth visits to document your visit? So Sanford Health went and did their own assessment of what they're doing, and they did an audit of their telehealth visits and realized that they billed for some telehealth visits when the physician was out of the country. Not really sure how that happens. And that they also did some that were audio only and not video, when only video was covered. So they did a self-disclosure, and because they did their own internal, their compliance department identified it, they then only got fined and penalized $25,000. And when I say only $25,000 for a physician practice, that could be a lot of money, but that's really good considering the fact that there are some multi-million-dollar fines and penalties related to this. This is another telehealth visit. This is a Feel Well Wellness Center where the physician was doing telemedicine visits. Unfortunately, they seemed to bill for telemedicine visits when he was on vacation. So it's really important that if you're going to do a telemedicine visit, that you should actually do the visit. And try not to be out of the country and not to be on vacation when that telemedicine visit is happening. And then make sure you're using the right type of equipment when you're having that visit. This doctor must have been on vacation a lot because it was a $2.6 million settlement. So pretty extensive. This is Savannah. There was a lady who had some DME companies, and she worked with providers, and she paid those providers for those telemedicine visits. So $60 million in Medicare fraud. She was in trouble. This is the rubber stamp one. So remember the provider from Savannah, the nurse practitioner who did the 3,000 visits where she just signed her name? This is Operation Rubber Stamp, where they just get these orders from companies. So telemarketing company goes out, puts out advertising. Do you have back pain? You're a Medicare person. We got a free brace for you. People go in, they fill out the form, they submit the form to the company takes that form, because now it's got all your Medicare and your phone number and all that information on it. They bring it to the doc and they say, we need an order for this back brace. Doc signs that back brace order, it gets billed to Medicare. So it's Operation Rubber Stamp. Same thing was happening with genetic testing. So COVID testing, big deal, right? We've all driven through a COVID test at some point in our lives. That's something I thought I'd never say again. But we've all been there. And so people were going to these assisted living fairs and assisted living homes and wellness fairs, and they were bringing these little satchels with them, and they were taking saliva test and nasal test, and then they were going back to the doc and saying, will you write an order for this genetic test? And the doc would write the order, they would do the lab, they would bill Medicare for it. Those tests, from a Medicare perspective, were $16,000 a pop. And those patients never got those results. They were all fraudulent testing. So Bloomberg did a big expose on it. It was one of those 60-minute kind of episodes. So with that good news, I would suggest that everyone make sure that you communicate with your patients about you do not give up saliva or don't do a COVID test unless you know who the provider is. And that we are not going to be sending you advertising for you to fill out your information online. If I think you need a back brace, we're going to do an assessment and we're going to figure that out. So the types of operations is called Operation Double Helix. That's what the government calls the genetic testing scams. Operation Rubber Stamp, where you just sign the orders, and Operation Brace Yourself is the back brace one. All three of those are going on in the state of Georgia. So we're going to continue to see fraud and abuse get recoveries under those dollars. Those are the bad guys that are going to hurt our ability to continue to expand telehealth. So that's why we have to communicate with our patients about this is the benefit, this is how we help you, and this is how we go from there. So I will stop there. Any questions? Are you coming for a question, Lloyd?
No, I'm
Okay.
going to turn the mic on.
Good morning. My name is Priya Rudretta. I and my CTO, we're out of the University of Florida. We're working with the Innovation Hub there, building a behavioral health platform for adolescents and young adults. My question to you is, I get a lot of questions about what's your business model? The model that we're trying to develop or really fill the gap for is behavioral health integration. There's a lot of physicians, a lot of pediatricians, primary care providers, and specialists that I've talked to who just don't receive any kind of, they don't have a referral network, they just really don't know how to deal with it. Do you recommend, or do you know of any reimbursement strategies that are employed, that are actually standards for behavioral health integration in Georgia and South Florida, in Georgia and Florida?
So Georgia, yes, they just passed the behavioral health parity law, so that if an insurance company offers a service for a physical exam, they have to do the same kind of payment for the mental health exam. So the insurance companies are going to be required to provide payment for behavioral health services in the state of Georgia. Florida, I don't know off the top of my head, but we do follow each other very closely. Like that telemedicine license thing is very similar, so we can definitely check on that.
So does that mean that the assessment is covered as well as the treatment is covered?
For the patient.
Okay.
Mm-hmm. Yep.
Thank you so much.
Anybody else?
with any physician that you're working with?
It's a great question. So our telemedicine companies consider business associates. Yes, and here's the reasoning behind it. So you are delivering healthcare services. There is a exception to HIPAA for a business associate called a conduit. A conduit means that someone gets information and they send the information across and they never access it. And they're not a business associate. But a telehealth provider normally accesses the information and stores it for you. That storage triggers that HIPAA business associate relationship.
So as a business associate, and they're required under HIPAA to do the appropriate risk assessment.
They are.
And basically keep their data secure.
Yeah. The only time that you would have a telemedicine company that wouldn't be a business associate is if they didn't do storage or they didn't access the information point to point. That conduit exception is really narrow. So yes, otherwise all business associates have to do administrative, physical, and technical safeguards.
And would that be the same requirements for health information exchange?
So that's a little different. You guys can speak to that. Do you guys do those same assessments? Y'all are just connect to connect.
Correct.
So it depends on the health information exchange. There are different models. There are some that take a provider and connect another provider. They're just a conduit between the two. They don't access it, not a business associate. There are some, in Tennessee, I think this is their model, they have a server, right, where they put all the patient data in the server, they store it, they become a business associate, and then people query it. So it depends on which HIE you're using.
So we do provide BAAs with our members. Yeah, BAAs.
So Georgia does have a BAA, and it's lovely. Anything else? Well, I really appreciate y'all having me here today, so thank you so much. I hope the rest of the day is great.